Hi guys, how are you all doing? I hope your week's been good. Welcome to today's webinar on access and canal location. Just a couple of housekeeping things. Obviously, if there's any issues with sound, as before, just drop me a message on the chat and I can see what's going on my end. And if you've got any questions, put them through the Q&A. We may do a little bit of polling as well as we did before. But any questions, even if they're not relevant to what I'm talking about at that particular time, just pop a question up in the Q&A and I can address that hopefully as we go through. So access and canal location, it's interesting because the first seminar we did on managing emergencies, I felt was really relevant to what was going on at the moment. And I've tried to keep this a little bit relevant to what's going on, to not have it as kind of a generic, just access and canal location. So to deal with, I suppose, some of the things that are particularly topical in that field. Maybe the influence of missed canals, because that happens to all of us in practice, I would say an awful lot of the time. And I think we want to know the answers to that question and how to communicate that answer to our patients without saying, for example, I'm sure it'll be okay, we'll check it in 6 months, but to give them some kind of evidence base to be able to say, look, this does happen from time to time, and there is some element of retrievability associated with it. So I'll talk a little bit about that later, specifically in relation to MB2s, because they're the ones that we seem to, I suppose, obsess a little bit about in the same way as we worry about separated instruments or perforation, whereas missing another canal or maybe accessing a distal buccal canal in an upper six, sometimes I can find quite difficult as well, depending on the tooth. So we'll try and keep it as relevant to practice as we can. Part of today in terms of the aims we're going to cover and we're going to look at, really we're going to look at the system that we use for access. So how do we set ourselves up in terms of kind of like a golfer, I'm not a golfer, but a golfer standing on a tee and they're doing a practice swing over and over. So what system do we set up for ourselves? How do we map what we do, both in terms of our own timings and what is the map that's available for us to make this a little bit more simple? And that really is massively important. I was thinking this morning as I was finishing off the preparation for this about dental histology, because a lot of kind of tooth development stuff comes up, and I'm doing a seminar later with our students in the university on the open apex. And it's interesting because a lot of that is kind of stuff that I don't cover a lot. I'm just going to pop out of this and go back into it actually, because something's happened with my PowerPoint. But a lot of that dental anatomy stuff really confuses me and I can never ever remember it. But that is massively important in terms of understanding how to find canals. Not because you need to know about cells and histology, but you need to know about the developmental lines on a tooth. You need to know about what the pulp chamber looks like. So I'm not going to go into the detail of it other than to give you a few tips about access and how you may be able to remember some of that kind of more confusing stuff. And also the point of today is that we get quicker at this for two reasons. First of all, I think access takes too long for me and for you and for everyone. And it's the part that takes the longest out of all of the treatment. And some teeth, for whatever reason, be it psychological or technical or maybe biological, we just kind of take too long and we get ourselves stuck in a rut, and we enter into this world of false economy where we're doing tiny amounts, thinking that that's going to advance us, rather than saying, okay, I'm going to step back, I'm going to take stock and maybe stop for today, or potentially take a radiograph or do something in order to kind of move us on to the next part of the process. That might involve, for example, and I do this sometimes in difficult teeth, if I find a distal canal in a lower molar, and I can't find anything else, I'll often instrument that canal coronally first, because it gives me way more of a sense of where I am. And sometimes you find when your access is really off that you think, hang on a sec, that's not a distal canal at all. That's one of the mesial canals. So that's just a small example of what we can do in terms of potentially not just looking at the access as a standalone part of the treatment, but rather a link, and I suppose an important link to the other parts. As a starting point, we need to consider that there are different clinical scenarios. Everybody listening today loves doing a central incisor. So where we go, okay, I've got a maxillary central booked in, I've got 45 minutes or an hour, I can do it single visit. I know there's probably only going to be one canal here. Very rarely are you going to have more than one. And I can get this done relatively efficiently, quickly, adhere to biological principles, and hopefully get a successful outcome. if we look at the images that I have up here, you do see lots of different clinical scenarios. So in some situations, for example, we get these calcified teeth, and I will talk specifically about these later, about the difficulties we face in terms of access, but also I think in terms of the tips and tricks that we can follow that are very obvious in relation to teeth like these. And then sometimes we get these retreatment cases where we've got a lot of tooth colored material right down onto the pulp chamber floor, a little bit of gouging of the pulp chamber floor from a previous treatment, or maybe from our own previous attempt to locate canals in a primary case. And that makes it complex to get back in there and find, I suppose, what we're looking for, because sometimes that initial map may be damaged or slightly affected by what we have done ourselves. And then other times you get restorative material, indirect restorative material. I listened to it's a really good YouTube webinar by Pascal Magnier a few nights ago about endodontic restorations of root-filled teeth. And he's a big fan of these kind of ceramic endo crowns, they call them. So a derivative of an iron core essentially, but all ceramic and kind of cemented into the pulp chamber. And I have to say, when I was listening to it, yeah, maybe in terms of bonding and retention, they may be of benefit, but in terms of retrievability, they're really, really hard to get through and get out. And you can see this case here. This is a case I treated a couple of years ago. I've accessed through this ceramic restoration, and then we've done root canal retreatment. I don't have the review radiograph, but it was successful. But I always worry about what will happen in terms of the retention of the restoration. It looks identical two-dimensionally on the radiograph. And although the emergence profile of the tooth, and you could say they're even overhangs as opposed to just a bulbous emergence profile, the margins of it clinically and radiographically appear to be sound. I've accessed through it. Ultimately, the outcome has been a successful one, but equally you wonder about the retention of your restoration afterwards. And I think that's something to keep in mind in terms of our access. The question is, what do we do during our access that affects the lifespan of the tooth structurally in a restorative sense? And also, what do we do in terms of our access that potentially affects the restoration that's on there already? When we looked last week at the idea of retaining restorations with satisfactory clinical and radiographic margins, are we affecting the survival of that restoration depending upon our access? And interestingly, a paper that is quoted a lot in relation to how detrimental access, I suppose in particular, but root canal treatment is, in terms of structural durability of teeth, is Rhea and Messer's paper from 1989, where they've actually found that a lot of the reduction in stiffness is done by the previous restoration of the tooth. So when they looked at, for example, an MOD restoration, a direct restoration, they found that stiffness was reduced by 62%. And that the stiffness, a reduction in stiffness due to the endodontic procedure is actually relatively limited. Now, that said, for me, and this is as practical as I can make it for us as Scottish dentists, a lot of the teeth we're treating have huge restorations in them anyway. And often that's the reason for the pulpal or the periapical pathosis. And so it's not kind of too simplistic to consider that, oh, well, the endo is only going to affect the tooth by 5%, because a lot of the teeth we're dealing with are very heavily restored already. And one of the questions that comes up a lot, and one of the people listening today, I won't name names because maybe the person doesn't want me to, asked about missed canals and how long you would look for a missed canal. And I'm going to deal with that question directly later, because that's a question that I always look for the answer myself. And I also look at how long my access should take me. And this, I think, is relevant to what's going on at the moment, because pre and post, I've called it COVID-19 or coronavirus, whatever, pre or post this current situation, it's going to be very different. Because I think dentistry, to reassure everybody, and this is just an opinion more than evidence-based, I think, of course, dentistry will come back because it's a necessary part of healthcare. But it definitely will change. And I think a lot of the hysteria associated with how it's going to change in terms of, you know, hazmat suits and PPE and different things, that's being developed. And I don't think it will go to one extreme, and I don't think we'll go back to where we were. But I think one thing that will be ingrained in us from this process is this whole idea of kind of socially distancing. And if you keep in mind that patients, when they attend the dentist, many of them don't want to be there anyway, especially for root canal treatment. And if we're going to be adhering to social distancing into the kind of medium term, you won't be able to have your waiting room full of people because you, like me, are having a bad morning and suddenly you're running late and you're 15 minutes late, mounting up to 25 minutes to 40 minutes, and patients are mounting up in the waiting room and you're thinking, God, I got to get through this. I think it's really important that our timings will be very robust. And I often say to our students, in terms of doing an endo access or a root canal treatment, I would like to see them mark out on a piece of paper 9:15 local administered, 9:30 rubber dam on, 10 o'clock canals located. And I think we're going to need to adhere to that, because sometimes it takes so long because we just get kind of engulfed in the whole process. We kind of become almost psychologically aware that it's a very difficult thing. And that sometimes is not a tooth. And I'll show you images later in terms of difficulty assessment for access. But that sometimes isn't a difficult tooth in inverted commas. It's a tooth that you look at and you think, okay, this isn't going to be so bad. But for whatever reason, it may be incorrect placement of rubber dam. It may be a patient who's a little bit mobile and is kind of moving around on the chair, or it may just be that you're not having a great day. Sometimes it takes us an awful long period of time. And I think we need to recognize that. And the false economy I mentioned earlier, we need to disengage away from that and stop saying, well, I'm going to keep looking here and doing the same thing and removing tiny, tiny pieces of dentine with an ultrasonic or a Longshank rosehead burr in an attempt to locate a canal, instead of saying, look, I'll instrument what I found and I'll come back to this later. Because remember that as a biological goal, that makes way more sense. If you've got a tooth and you suspect that there are, let's say, 3 or 4 canals in it, and you locate 2 of them, and you say, well, I know what I'll do. I'll look for 45 minutes for the 3rd one, and suddenly your appointment time is up and you need to get the next patient in. Number 1, you've achieved very little biologically. Number 2, you're probably likely to cause a flare-up for the patient. And number 3, you then have to face into the exact same problem again the next time. And you find yourself saying, well, I should have just instrumented those 2 canals. So don't engage in that idea that you must keep banging your head off a brick wall and looking. Take a step back. It might involve a calcium hydroxide dressing. Instrument the canals that you found. Take an intraoperative radiograph with a burr in situ, stabilized with a little cotton pellet. Don't ever put a burr into an access cavity and then say, I'll take a radiograph. You have rubber dam on. You fold it up and you take your radiograph, and what happens is that the burr disengages from the depth of the cavity that you've drilled, so that when you look at your image, you say, okay, I've got a few more millimeters beyond which I can advance before I'm into a danger zone. But all that's happened is your burr has lifted a little bit coronally by a couple of millimeters. And when you go back in and you access further and deeper down towards that area, you end up perforating. So if you're going to take an intraoperative radiograph, then you have to get some kind of information from it. One of the other difficulties I often have, and I have to say I do this so often, relatively speaking, I don't take a lot of intraop radiographs to find canals, but when I do, especially in anterior teeth, sometimes you take a radiograph and then you look and you think, damn, I should have taken off the rubber dam clamp, because all I can see now is the burr just poking beyond the end of it. And if you're off angle and you come in too high with your beam, it's even more confusing. And that can actually be quite difficult. So I'm not advocating taking the rubber dam off. But what I'm saying is you need to be very conscious. If you're going to take a radiograph, you have to be able to see the burr that is there. Someone has asked as well for an image of taking a radiograph with the burr in situ. What I can do is I can give the information for this stuff to Magda, and she can email it out to you afterwards. So she's got all your details, and I will make a quick note now, and I will send on a diagram of what I mean, because I want to have a chat at the end as well about what you want in terms of CPD going forward, not just from me, but from the practice as well. We were chatting about it last night and trying to figure out what would be best. But I will send on the diagram with the burr in place. I think then you need to ask yourself, in terms of access, what's it meant to look like? And this used to really annoy me. It used to be kind of like I developed these kind of little obsessions that irritate me within endo sometimes. And I remember for a while I was thinking, how can single cone work, until I looked at the evidence, and the evidence actually isn't strong one way or the other. And actually with a lot of the bioceramic sealers, a lot of people are using single cone now. But one of the things that was driving me crazy a few years ago was this idea of a ninja access, and the perception that if you weren't working towards doing this type of access, that what would happen essentially would be that you would be left behind in endo, and that you were doing a conventional or a traditional access cavity, or even a conservative access cavity. So the green one in the middle wouldn't have been sufficient. And then I said to myself, why are we doing this? And if the argument is you're doing it because you want to avoid weakening a tooth unnecessarily, then I would like if somebody looked at that. And Platino thankfully did look at that. And they found that if you compared the green and the red on these images, there was no difference in terms of the fracture strength of endodontically treated teeth. And the purple one, okay, it's a traditional design, they call it. It's probably too big. And sometimes we do an access cavity that is too big. It's not the end of the world, especially in the heavily restored teeth that we see. But in teeth where you are trying to conserve tissue, either ceramic often or dentine and enamel, it's better if we're going for a green or a red design here. But there's no need for it to be this tiny access cavity marked out as red here. So that if you do access it, the difficulty you have is that it's really hard to see what you're doing. You have no light getting in there from your light source. It's really difficult to take an intraoperative radiograph with your cones. So you do what everybody does in that situation and you try to do it. And then you say, look, actually, I don't think I need it. It's too difficult. Or you take it with less cones in there than our canals, or alternatively, you take multiple radiographs, and all of that just doesn't make sense to me. An endodontic access cavity, as the name would suggest, is designed for us to gain access into the root canal system. So if it makes it more difficult and it doesn't do anything in terms of improving the fracture strength of an endodontically treated tooth, then for me, the access should be appropriate in size. I'm not saying it should be big and I'm not saying it should be tiny, but I'm saying it should be an appropriate size, adhering always to the principle of trying to maintain tooth tissue or restorative material if you're going to leave the restoration in place as best you can. And that's really the goal that we are setting out to achieve. And if you're doing that, you're going to end up with a satisfied dentist, you're going to end up with a satisfied patient, even though they won't know it, and you're going to end up with a satisfied tooth that will probably last you longer. And I think one of the key parts is, and I talked about this on the second slide, is understanding that teeth are different. And that some teeth, when you look at them, and when you measure your distances and you orientate yourself in terms of the angulation of the tooth, you understand that the access will become a little bit more complex at different points as you go through it. So for example, the image on the left side, as I look at it on the screen with the red and the dark line, that access becomes complex as you start to advance down towards the pulp chamber, because you're not going to get that kind of sinking feeling where you're going to fall into a pulp chamber. And I always find that kind of not reassuring in any way, because you'll get the same sinking feeling if you fall into the PDL. So looking for the sinking feeling in teeth in older patients with calcified root canal systems and narrow little pulp chambers and even pulp stones, it's a fool's paradise, because you may not feel it. And if you don't feel it, again, psychologically in the back of your mind, you're thinking, this isn't going well. Why am I not finding this? Why am I not feeling this? The measurement of teeth for me is something I have moved slightly away from. I do measure sometimes the distance from the corona reference point down to the furcation area, which is the red line on the image. Not necessarily the dark line, which is the reference point to the roof of the pulp chamber. And the reason for that is that I am either terrible at counting from 1 to 8 or 9, which is roughly speaking what your distance is, or else it's never accurate, either due to the fact that the software isn't calibrated perfectly, or due to the fact that where you're putting your little cursor is not exactly where you need to be three-dimensionally in your tooth. And so what it does, again, is it adds a false sense of, I suppose, being definitive with something that really is a fluid thing as you access into the tooth. And so for me, I do have one eye on the fact that, let's say the red line measurement here is 10 millimeters. If I'm advancing down to 7, 8, and I'm thinking, I don't have a canal here or a pulp chamber, then I'll probably stop and I'll take an intraoperative radiograph with my burr in situ, because I'm thinking the 10 millimeters isn't necessarily enormously important, but I know that roughly speaking to about here is going to be 6 or 7. So if I'm down around 8, I'm going towards the end of my red line. And that's the part that's really important. Because, okay, if you gouge the pulp chamber floor, you might weaken the tooth slightly and you might complicate your location of your canals. But if you perforate a tooth cervically, we looked at this last time, depending upon its size, depending upon its location. So it might be that you go off angle and you come out here. And depending on how long you leave it there unattended, unfilled, undressed, the worse an effect that will have on the outcome. So for me, I don't want to overcomplicate it. And in terms of the lines or the measurements that I take, I do try to keep those as simple as I can. If you look at this tooth here, this is a tooth that was referred in for canal location. I can't remember this. I think it was to the EDI. But actually looking at this, the shape of the access cavity is not bad. It's quite a decent size. You can see that it's a good depth because it's sitting right on the roof of the pulp chamber, but it's just that the orientation of the access is not correct. And actually this person, when they did it, really knew what they were doing, because they stopped just in time to the point where they said, I should be finding canals here, what's going on? And they would have been resting right onto the pulp chamber roof at that stage. And in a tooth like that, it probably would have been relatively easy to find the distal canal. And then you say, well, okay, this is simplified now. I know where the distal canal is. So therefore I should find it easier now to get into these mesial canals as well. So for me, they have stopped at just the right time, but measurements and lines and different things aren't going to help here because the orientation is slightly off. And if you come out at this point, it makes it a much, much more complex treatment than if you don't. And interestingly, two things have happened here. Look at the orientation of the tooth. It's just kind of off angle, isn't it? It's just sitting in a slightly, because it was a mesial tilt. And equally, it's heavily restored. Lots of composite up on top, and that composite looks to be nicely contoured. Okay, this is one of the things that is slightly counterintuitive, but it's nicely contoured. So you're saying, okay, it's nicely contoured. And then you follow that and you say, well, this is what the tooth looked like, but that's not necessarily true. You can contour a composite nicely and it might be nothing like what the tooth looked like before, depending upon how it sits in the occlusion. So don't always trust what is there either, in terms of, it's often a crown we talk about and we say, well, the tooth might be at a completely different angle, but it can be the same with the direct restoration. It's not necessarily about it being completely in a funny position. It's just that your natural reference points are going to be missing. And if your natural reference points are missing, you will sometimes be led astray in a situation like that. And rubber dam often comes up as a part of access, because sometimes people will say, you know, should you put rubber dam on before treatment? Should you put it on after you do your access? And rubber dam is kind of useless actually in certain aspects of access. And these are all cases I have done. I like putting up the cases that aren't, the ones that I'm not happy with. It's not to say they didn't work out, but I look at them and I think, what was I thinking when I did that? So the rubber dam placement on this tooth that you can see in the image is fine, no problem. Well adapted cervically, some oral seal around it. But for me, there's no four-walled cavity. So doing access in this tooth without a four-walled cavity, looking for canals and trying to instrument them is crazy, because not only biologically does it mean that you're going to have something leaking in or out, but also what happened was, because I was so preoccupied with whether this was leaking, I ended up perforating in the floor of the pulp chamber. And you can see that there's an MTA repair there. And that's my fault. I hold my hands up there and I say, that was just not sensible to do it that way. And then if you look at the tooth over here, really built up lateral incisor, wedges holding the rubber dam in place, and you'll see the next image as well. Rubber dam is useless in a situation like this for two reasons. First of all, you're not achieving your biological goals. That's the problem. And the second thing is, if the rubber dam isn't placed properly, like it isn't here, it will move up onto the surface of the tooth. And in a situation like this, it's not such a bad thing. But I would definitely still say this tooth should be built up first. And pre-treatment with GIC or whatever material you want to use, endodontic pre-treatment is important. And we talked last week as well about the idea you could put the definitive restoration in, the definitive composite, and re-access through it if you wanted to. But pre-treatment is really important, because it means that you're adhering to the goals and you will get a better result in the end. The other thing is, if the rubber dam is riding up onto the palatal or the lingual surface of teeth, and I'll talk specifically about lateral incisors, mandibular lateral incisors later. If it's doing that, and I always say this when I talk about these images, one of two things will happen. In a best case scenario, what will happen is you will access and you will keep going and keep going. You'll identify that the rubber dam is in the correct position. or in the incorrect position rather, and you will either pull it down with your fingers or you leave it there and the burr will catch it and kind of give you that shock where you jump back. Patient gets a shock, you get a shock, and you kind of go, okay, I need to put the rubber dam on properly. To do it properly with multiple teeth, it's hard to use a butterfly clamp in the anterior region if you're doing multiple teeth. Sometimes what I will use is I will use a deciduous premolar clamp, which is an E-clamp, because it adapts really nicely cervically to especially a mandibular incisor. And it means I can put it right down at the gingival margin, which will mean it's not traumatizing soft tissues, but it's retracting the rubber dam correctly. In a worst case scenario, what will happen is the rubber dam will ride up and you won't prepare your access cavity correctly. Very, very common in mandibular anterior teeth. It will be very circular, it will be very incisally placed, and you'll miss the lingual canal. And if you miss the lingual canal, often that will have a profound effect on outcome, and it will mean ultimately that you may end up needing to retreat that tooth. So the placement of rubber dam, yeah, rubber dam is useless in situations like these, but it also depends, and I suppose this is kind of relevant to what's happening going forward. It also depends on why you've got it on. And I think the majority, the vast majority of the literature on rubber dam and its effect on aerosol production is positive. So it will say, some papers have huge figures in terms of aerosol reduction, up in the 90% range. Some of them are less, and there is only one study that I have found that is quoted in the literature that talks about rubber dam increasing the aerosol production. I have to say, I find that really hard to believe if the rubber dam is placed correctly. I think our protocols in terms of rubber dam will change slightly, but one principle that will become way, way more important is it should be put on correctly. You can't have it leaking from within the oral cavity for obvious reasons. You ideally should have it positioned correctly on the patient's mouth so that it's not resting down with a large portion of the mouth that is open. Historically, that was because people didn't want to drop files or various things in there. For me, practically, it never worked because it meant it was too taut at one aspect and it was too difficult to get the instruments in. So it had a profound effect on your ability to access and find canals. But I think going forward, you're going to want to have the mouth covered, I think. And the patient's going to want you to do that too. In terms of its positioning in relation to the nose, I don't know the answer to that. I love to have the rubber dam down underneath the nose because I have to say, I don't fancy having rubber dam on over my nose. One question that has come up in relation to the core buildups is, would I advocate doing it in the same appointment as starting the endo, or would I advocate a separate appointment for it? It's a really good question. And the other part of it is, how do you charge for that? So do you charge for the final core, or do you charge as part of a pre-treatment? We don't. It's an overall kind of cost in terms of the charges for the patient. And it's a good question because, you know, it's kind of like, I always compare it to when football managers are complaining about bad decisions for penalties and stuff, and they say, oh, I'm sure it'll even out over the course of a season. And it does. Some core buildups I'm really fast with. Restorations are easy to take out, very quick to build up. Some aren't, and they take me ages, and I just have to take that hit, as it were, and just say, look, this is taking longer than I thought. I wouldn't ever take a core out, rebuild, and not access or do partial access at a visit. The problem is sometimes if we think, well, I've got 15 minutes, I'll do a little bit of instrumentation, you're probably likely to cause a flare-up. So if I got the core out and it was taking me forever, and it happens to me sometimes with post removal, I probably would just rebuild it and leave it and know there would be no charge for the patient. But I try to difficulty assess this at the outset. And so, for example, if I've got a first stage coming in where the core needs to be dismantled and rebuilt, I might book that for 1 hour and 15 minutes to do the instrumentation as well, and then maybe book 1 hour for the obturation at a visit 2 weeks later. But you're trying to assess that, and I think it's a good question because practically speaking, I don't have a simple answer to that other than to say, I try and make an estimate, and sometimes I run a little bit late to contradict what I was saying earlier. But if I don't think I can achieve the biological goal of the next part, as it were, i.e. finding, locating, instrumenting the canals to reduce the bacterial biofilm to avoid a flare-up, I'll probably park that part of it and I will move on. I think the other thing to consider as well is about this aerosol transmission in dentistry, and this has become an incredibly famous paper over the last few weeks, to be fair. But a lot of the stuff they talk about in dentistry, they reference the use of rubber dam, and they talk about the fact that within this paper, nobody in the dental school, they think, although this is very difficult to prove, I have to say, nobody became infected as a result of doing dental treatment. And that, again, to reiterate what I said earlier, in terms of your timing and in terms of your strategy and in terms of mapping out your access and your canal location, they were talking about a lot of the socially distancing stuff that needed to go on in the waiting room. And again, I cannot stress that enough. That is something that is now part of how we live. And that will, if you want your practice to work afterwards, and you want to, I suppose, keep people comfortable and keep them happy and satisfied, timing will become a very important thing, because, you know, there are going to be big differences in terms of disinfection protocols, and our timings will become really important to us, but also very important in terms of how the flow through goes through the practice and goes through the hospital to allow patients to come in at their allocated time, so that we're not necessarily running late. And then I do think you need the right gear for access as well. Although I have to say it's massively overcomplicated, as it is with everything in endo. This is a slide from Dentsply, which is just, as you can see, a burr measured to your pulp chamber. It's interesting that they're doing access with the cavity at the mesial aspect of the tooth. And it's just crossed my mind in response to the previous question about, you know, do I do a separate appointment for the core buildup? I spoke last week about doing multiple tooth isolation, and that does mean that sometimes it's much simpler to get the core out, locate some canals, especially in a tooth that, for example, has an irreversible pulpitis, where you don't have to instrument canals fully, but you want to get a patient out of pain. And it might mean that you could do your instrumentation, for example, in an upper molar, without rebuilding the tooth, quickly get in there, instrument, get a little bit of maybe leather mix or odontopaste or whatever your choice of medicament was, and then rebuild quickly at the end. So there are kind of little cheats or little ways around it, as it were, also. But yeah, you do need the right gear to do an access. And for me, I like having a long tapered burr. We spoke last week about accessing teeth. You've got to have a diamond to get through ceramic. You've got to have a tungsten carbide to get through metal. But if you're going to go through some kind of restorative material, I do like to have a long tapered burr. I do my access under rubber dam because I find it easier. But the reason I like a long tapered burr as opposed to a short burr is that I can see what I'm doing. And this is the part I want to see. I want to see what the tip of the burr is doing. I don't want to see a big massive spray of aerosol and water and me being unable to see. It's the tip of the burr that you're looking at, because that's the part that's going to cut the floor of the pulp chamber. That's the part that's going to affect your ability to cut a nice shape to make canals easier to locate later. And so I do want to see that. I have no objection to using a shorter burr to do the initial shape. I think it's easier sometimes, and it's just, it looks nicer and it's neater. And those burrs by definition have smaller little tips on them as well. So it's a bit more conservative. But when I get down into dentine, I don't want a short little burr in this handpiece, so that when that burr is down here, the head of the handpiece is resting on the occlusal surface of the tooth. I can't see what I'm doing. Some people as well advocate turning the water off when you're accessing. You can definitely turn the water off. We're not saving pulps here when you're doing root canal treatment, and the amount of heat that is transferred, even with the water off, is minimal, depending on how long you're doing the access cavity for, but is minimal. It's not like taking a post out with an ultrasonic at high power. But if you're going to turn the water off, you need really good suction because it smells pretty unpleasant, and you are at some point going to also need to put water on because you've got to clear away that debris. So trying to take an amalgam out, for example, with no water on, again, is false economy, because you'll think, oh great, I can see loads because there's no water, but you can't, because it just creates that massive amalgam sludge, and you can't kind of see your way through it. And I think that that is difficult. Someone has asked as well, would I use a round-ended burr like this? I don't actually. I've just stolen the image because Dentsply kindly provided it to me. I use a flat end on mine. I historically liked what was called a 630 burr, but I have found that that's too wide, and this will highlight my ignorance about the variety of burr systems that are there. I have a burr in practice now that the girls ordered, and I never even asked them what the number was because they're very good at ordering and making sure that the surgery is stocked. But I just say to them, can I get a cylinder, is what I call it. And they know then at that point. And to be fair, there is a massive box of burrs, but I look in and I say, that's the one I want. And I like that simplicity. And the reason I like that simplicity is that, number one, I know that the burr will be there, and it always is. Number two, my thought process is simple. I think, yeah, this is what I'm going to use. And I'm familiar with it. And number three, the monotony of the familiarity is what makes it easy for me, because I know the system and I've used it loads of times before. And when I talked about Kvist and Wright's paper last week about decision-making in endodontic retreatment, a lot of it comes down to, although we have a lot of knowledge and a lot of skill, we apply our decision-making onto a set of basic heuristic principles. And that essentially means we do what we know works in our hands. And I never was in favor of agreeing to that because I didn't think it was evidence-based. But of course, that's what we do in a situation like this when we do an endodontic access. Of course, we do what works in our hands. And why wouldn't we if it works in our hands? It would make it much, much more simple. And this really is, and I try to make these seminars not too academic. I try to put papers in that are relevant to what we are doing in practice. This is an enormously important paper, this Krasner and Rankoff paper. Now, there's a ton of detail in it, but to simplify it, what they're saying is, number one, you've got to know about the general anatomical features of teeth. So for example, lower lateral incisors will have extra canals in up to 40% of cases. That's not in 40% of cases, but up to 40% of cases. If you look at the maxillary first molar, MB2 will be there on an in vitro basis 90% of the time. So that's the Sun headline, MB2, 90% of cases. But then when you looked, the Times would tell you, well, actually, in most studies, it's there about 70% of the time, maybe slightly higher when it's actually treated. So that would be the actual factual headline. Krasner and Rankoff also talked about symmetry, they talked about color change, and they talked about laws of orifice location. So what they said, and this doesn't help with maxillary first molars, which is great, but what they said was teeth are symmetrical, and this is the histology part. So if teeth are symmetrical, if you chop them in two and you stuck them together, you would be able to match the two sides. Makes sense. So those developmental lines that you see are essentially the map that will tell you how you're going to be able to see where these canals are. So if you drew a line through the middle of a tooth, it would be symmetrical. If you drew a line perpendicular to that line, the second white line here in image A, your canals would be located along that line. They talk about the color change of the pulp chamber floor. The pulp chamber floor is darker. So that means that if you get in there and you see darkness and you're looking, drilling, and then suddenly that darkness is turning lighter, you're probably going through that pulp chamber floor and into the root dentine. It doesn't mean that you've made a mistake, and it doesn't mean you're going to perforate, but it means that if you don't stop soon, there is going to be some issue for you. And the laws of orifice location really talk about the idea that the canals are located at the junction of the wall and the floor. That's really the important part, that they're kind of at that point. So what we take out of that in terms of practice is, number one, don't go too deep. Look at the darkness of the pulp chamber floor. Number two, follow the developmental lines so that if you find one little dot or one canal, just trace across to the opposite side of the tooth along that line. Don't pick a point and go, you know what I'm going to do? I'm going to go right for this point. I'm confident. Bang. There you go. And suddenly you're not in the right spot. And the other thing is, don't make your access too big. Because if you make your access too big, especially at the junction of the wall and the floor, so if you end up over here and you should be where the black dot is, it's really difficult to get the instruments in afterwards. So you're kind of hitting a ledge at the corner between the canal where it should be and where you've created your access, that little iatrogenic error. So in practical terms, for you guys, that part is much, much more difficult, much, much more difficult, rather than people saying, oh, well, if your access is too big, you're going to destroy the tooth and it's going to be X% less stiff. Rhee and Messer have discounted that, and that was like 31 years ago. So don't necessarily look at all those negative academic kind of aspects of it. Someone has asked as well in terms of whether or not you're using water. If a tooth's necrotic, can you access without water? You can, and they've made a good point of the question, which is even with the smell that's there, and it is a balancing act, you know, because I'm all about the patient comfort when you're having a root treatment done, because it's unpleasant enough as it is from a patient point of view. But I will kind of alternate, and I will use a common sense approach in relation to that, so that if I do access through and then suddenly it stinks really badly, I will turn the water on and I will just say, I'm going to need to slow down here, and I'm going to need just accept the fact that I'm going to need to keep cleaning my mirror. So I always have a piece of tissue or gauze. It's weird because I have two different systems. When I treat patients in the EDI, my nurse will hold the gauze for me, or the tissue, so I'll just hold the mirror out. Whereas in the practice, I hold it myself, and part of that, you would think that's me being kind of precious, but it's not. It's just how the instrument trays are set up. They're slightly different. So in practice, all of the endodontic instruments are on the left side, so I don't have any of them on my bracket table. Whereas in the hospital, all the instruments I need are on the bracket table on my right side. So it's just those subtle differences. Both systems work well for me. I am not that precious in relation to that, but I think you have to have something to wipe your mirror, because the number of times when I am supervising on the clinic and I go down and someone's looking for a canal or doing an access, and I'll look in the mirror down the scope, and the mirror is kind of like not even wet or really dirty, but kind of smudged, you can't see what you're doing. And the same with scratches on the mirror. I don't throw one away. You know, it's not like I wear a new pair of shoes every day. But I don't want a mirror that has scratches, because it's just, it makes you angry, doesn't it? You're looking at it and you're kind of thinking, oh, if just that scratch wasn't there, but it is there and it's not on the tooth, you know? It's kind of like watching a fly walk across your TV screen. You know, sometimes you're just too lazy to get up and swat it away, but really it would be much more enjoyable watching the TV if it wasn't there. In terms of finding these canals, then I think one of the things that often comes up is, well, I can see the canal, but you know, there it is. And this is a great article, and I don't recommend too many papers, and we do have time now, but there's having time on the one hand, and there's reading endodontic literature on the other. And I don't know if anybody is that bored yet that you want to start delving into this stuff, but this is a great paper. It's done by a guy who is an endodontist in Galway in Ireland. He, let me go back. So he is, he also works in Cardiff with Paul Dummer, who's the editor of the International Endodontic Journal. So for someone in practice, he's produced a lot of literature that is very, very relevant. And I think that's important, because it's not just academic stuff. And this paper talks a lot about the incidence of canal obliteration. It talks about the presentation of it, you know, this discolored central, for example. And one person has asked, is it an endo mirror I use? 100% it is when I'm accessing, because I can't see down the scope. It's got a funny reflection otherwise. But when you look at this image, you can see that there is something here. Okay, you can see there's the canal. Definitely, that's what it is. And it doesn't look like a black dot. It doesn't look like something that's a different color. You can just see there's a little strip kind of running across here. And so we know the canal is there. And sometimes, even in standard maxillary central incisors, I access them and I think this is way harder than it should be. And I think part of that is psychological. I think that you're thinking this should be easy, and why is this not very, very quick, and in you go. But here's your canal. So you can see the canal and you're thinking, okay, so what's the next step at this point? And one of the things we look at here is you have to trust your instinct here. This is the canal. So if you follow that point and that little calcification, that little dark dot, or that little tiny, it's not a dot, because remember, the canal was big at some point, and then it calcified and calcified and calcified and calcified and calcified, but it didn't all calcify into one dot. They calcify in different ways, and there are dystrophic calcifications that occur. So just look for something that looks a little bit different and say, well, okay, and don't be afraid as well. Sometimes I'll tilt my head away and I'll look at the side of the tooth, or I'll take the rubber dam frame off and I'll pull it down. So that when I'm looking, I'm saying, okay, so it's roughly in the right spot as well, because it's in the middle of the tooth. And be careful accessing maxillary anterior teeth, because when I see teeth that are perforated, it's invariably to the labial aspect of the tooth, not palatally. I've seen one palatal perforation of an upper central incisor ever in all my time doing endodontics. So you're looking at 11 years, one palatal perforation from access, but I've seen, I would say, probably into the hundreds of labial perforations. So keep that in mind as a useful kind of tip to take away from today. When you're accessing, you are too labial. Everybody is. We are all too labial when we're accessing maxillary centrals. So do look and see, well, okay, I'm roughly in the right spot. I found a reference point. Krasner and Rankov said there was a color change. I can see something here. And then at that point, you need some tips and you need some ways to help you, because you're saying, okay, you don't need someone to say, yeah, it's a canal, but you need confirmation, because in your mind, you're thinking, am I right here? I do have a song to play here, but I don't know if it will work. I don't know if you can hear this, but I'll turn it down because it will help to bit of light relief for talking about endo. But people talk about the effect, the champagne effect of when you put any type of irrigant onto a root canal orifice. So this is our same image. This is our same tooth we're looking at. Now it's becoming a bit more apparent, and you can see this little calcification that's there, and you're trying to chase after that, okay? So people will often talk about the kind of the champagne effect of hypochlorite. So you put it on and you get bubbling. That is only useful when you reach down to this level, okay? So otherwise, when you put it in, and this is why I always as well use a cavitron or some kind of ultrasonic to clear the debris around the access cavity when I do it, okay? So ideally, when you reach the point where you're looking for a canal that is hard to find, there's no point in having a ton of debris everywhere else. You need to have a very clean and well irrigated cavity at that point. So that theoretically, the only place the bubbles are coming from is there. And then people will say, well, what I do is I put loads of hypochlorite in, and then I wait to see bubbles. But you'll see bubbles from everywhere. And it would be like looking for a 2p coin in a swimming pool. And someone saying, you know, can you see it? And you say, I think, is that it down there? And you would identify loads of other small things that are often floating in swimming pools, but that weren't the 2p coin. So for me, what you need to do at this point is you need to dry this off completely so that it looks like it does in the image. And then you put a drop of your hypochlorite in there. Just a drop, 1 or 2 drops, and you cover this little orifice space. And when you cover that little orifice space, you will then start to see the bubbles will start to emanate from there. And that is simply confirmatory. The same thing will happen with EDTA, but to a lesser extent. Hypo is better at doing it. And hypo is will have more of a cleansing effect as well, I suppose, in terms of the bacterial biofilm. So I'm using hypo. I don't intertwine and interuse my EDTA, because we know from the literature that EDTA has a negative effect on the tissue dissolution capability of hypo. And I don't see a need to start mixing it. And that's not how my surgery is set up. I don't have EDTA when I'm accessing a tooth, okay? Unless I'm going to do it a single visit, and my EDTA is my penultimate rinse right at the end of the treatment. But I put my drop of hypo in there and I wait to see the bubbles. And if I see the bubbles, then I will say, okay, confidently, I'll dry it again. I'll get something and I will start to advance down apically. And I repeat that over and over and over and over again until I get into that canal. Now, the difficulty sometimes is trying to decide what is it that you should use. Should you use ultrasonics or burrs? And as I say, I try to keep this as relevant to practice as I can. An ultrasonic unit like this on the screen is expensive. It has multiple other uses, and if you were doing a lot of endo, yeah, 100% I would have one. But if you're working in general practice and you're thinking, well, I do a bit of endo, but I don't want to invest £3,000 in an ultrasonic and then have all the tips. And then also the fact that for me, ultrasonics are not ideal at finding canals. Refining access cavities, yeah, they're good. Taking posts out, they're great. Activating irrigant, really good. But finding canals, no, for 2 reasons. Number 1, they gouge the pulp chamber floor. So you've got to be in the right spot. And number 2, canals that you're looking for are heavily calcified. So you're creating an awful lot of debris. And if you're creating an awful lot of debris, you have to keep rinsing and drying and rinsing and drying and rinsing and drying. For me, I use a lot of pulp chamber burrs, goosenecks, long shank rose heads, call them whatever. Now you've got to be appreciative of the fact that they are different sizes. That's what you're taking caries out with, generally speaking. Whereas you're using a lot of 100 and 120s. But when you use a burr like that, it will create minimal debris, because the debris, because of the speed that the burr is rotating and you have suction on it, often that debris is coming back out. Whereas you won't have that with an ultrasonic. And they're way cheaper in comparison to investing in something like that. But even if it wasn't for the financial consideration, I use a lot of these, an awful lot of these. I don't use a lot of ultrasonics in terms of accessing canals. Okay, when the ultrasonic comes out for me to get into a canal, I'm at desperation stakes at that point, and then that makes it very, very difficult. Someone has asked as well in terms of the concentration of hypo. I use 5.25%. I'll talk about that. We're going to do an irrigation seminar hopefully next week. I use 5.25 because if you use it safely, it's got high tissue dissolution capability, it's provided in CE marked bottles, and that stuff is very, very effective. The higher the concentration, based on a study many years ago by Moore and Wesselink, theoretically the less you have to put in, but why not use a high concentration? In terms of hypo accidents, they're a very rare occurrence anyway, so it doesn't influence my thinking in terms of my choice of hypo concentration. So then you end up at that point where you've accessed in, and this again is another microscope image from Paul McCabe. And you end up in a situation and you're saying, I can't get a file in here. So you've got a case like this, and you can see this is the part with the restoration on top. This is the part where the rose head, oh, that you won't see that with the cursor, so I'll pop on the pointer. So this is the part with the rose head, and then you're saying to yourself, okay, I can't see a canal in that tooth, but suddenly you find a canal. And remember, canals calcify from the top down, top down. Very, very rarely will you see a calcification occurring apically extending coronally. It would have to be if you put something like a kind of a fixation plate into the apex, because it's such an unnatural physiological phenomenon for it to happen, because the insult is often felt up here in the majority of cases than down here. So when you get in, often you will find, you open it up and you're saying to yourself now, at this point, I know that there is a canal here, I can feel it. And you might take a radiograph with a burr in situ at this point, and the burr is sitting right on top of what you think is a canal. Or you may equally find when you take the radiograph that the burr is sitting ever so slightly to one side or the other, but that you can see where the canal is. And that's equally as confirmatory. You don't have to take the radiograph. Sometimes I find it almost a pain when I look and I take the radiograph and I say, yeah, I'm right there, but why can't I find the canal? Sometimes you find if you're slightly off angle, you go, okay, right, now I can see why I can't find the canal. You correct yourself and bang, in you go. So sometimes confirming that you are in the right spot is kind of less helpful than confirming you're in the wrong spot. So don't look on that as a negative and beat yourself up over it. You're doing a good job when you're taking an intra-op radiograph to correct your access. But you do find then sometimes that you've got a file and you're saying, oh, wow, I can't just engage it, but I know that this is the canal. And this is possible in very limited cases, but don't be afraid to cut the end off a small hand file, like a number 10, okay? And that will make it end cut. Get a scissors, because you'll have a ton of bent hand files at this point. And okay, at their cheapest, they're £1.75. But why do you want to waste them? Think of the environment if you're not thinking about the money. Why do you want to keep throwing away the files when the 90% of the length of it is actually usable? So you can cut the bent bit off and use that and twist it, twist into this area. And often what that will do is it will free up a calcification that is remaining here, and suddenly then it will move a little bit apically. Now, immediately when it does, you then want to stop. And what you want to do is you want to go back to a smaller, intact, preferably new hand file, and you start to negotiate in there, and you sequentially crown down your way down towards the apex of that tooth. But don't be afraid to play around with that. It doesn't, cutting the end off a file is only appropriate where the tooth doesn't have a curvature, and where you know, and you will know this yourselves, and I say this to you as a knowledgeable audience, you just know when you're in the right spot, and intuitively you're saying, I just can't get in there. But then you have to wheel out a different part of your armamentarium. You can't just keep, you know, going, well, I'll keep looking and keep looking, or I'll get an ultrasonic. And some people say, well, isn't cutting the end off a hand file aggressive? Of course it is. Absolutely, it's aggressive, and the file is more prone to breaking, and you're more prone to going in the wrong direction. But it was an endodontist in London who supervised me when I trained, a guy called Howard Lloyd, and he does some amazing work. And when I saw him doing it, I was thinking, you can't do that. How can you cut the top off it? And I do it all the time now, because it's a really useful little tip, and it's far less aggressive than putting a long shank rose head and continuing to cut into an area where you know a canal is located. So you can play around with that, but as I say, you need to be careful, and really, in a way, it's kind of confirmatory as well. And the other thing is that you need to consider it as a kind of a last resort, kind of like when you're getting an ultrasonic out and you're saying, for me, when I'm looking for a canal with an ultrasonic, I know that things aren't going amazingly at that point, and I'm feeling the pressure. The other thing to consider as well is about your how this relates to your access. And this is a great, this guy, Terry Pancook in the States, he does some really good webinars on some really good surgical stuff, really good one. There's a great one, I got this on LinkedIn and I got his approval to use this image. But there was a great one on LinkedIn about how to, his assessment of and management of a calcified canal. It's a webinar, you'll find it online. But he talks about a strategically extended endodontic access. It's a very apt way of describing it, because you can see what he's done is, this isn't a ninja access, this is an appropriate access. It's got a little ear cut into it in order to just allow access into this part of the root canal system, because otherwise you can't do it. And sometimes you're thinking to yourself, I've done this and I know there's an MB2 here, but I just can't get in there because this piece of enamel or dentin is kind of resting over the top. So get rid of it, take it away. Don't chop the marginal ridge to pieces, but create an access cavity that is appropriate for you to find the canals, because ultimately that's what the access cavity is for. It's to find the root canals. And then that brings us on, that last image, to this dreaded kind of MB2. And I've talked about adjusting this outline pattern. Do that, okay? So that if you're accessing and you think, if I could just extend it a little bit, you're making the decisions here. No one's watching over your shoulder. If you think that's appropriate and that will help you, it's better you look for your MB2. You might not find it, but it's better that you look than if you don't look. And always trough between MB1 and MB2. You don't want to end up in a situation where, again, as I said earlier, you're picking a spot and you're going, okay, I'm going to go, bang, this is it. I'll go right down here, and you're wrong. Why take the risk? Dentists are risk averse by our nature. So why is it looking for a canal? We'll say, oh yeah, whatever, I'll just go in here. I know it's right. And look at the image that's on the screen. It's a premolar. It's a premolar. If I get, and I say this every time about MB2, if I gave you an upper premolar and I said, how many canals will that tooth have? You'd say 2. Where will they be? Buccal and palatal. And I said, okay, will you find them? You'd go, bang, bang, there you go. It is, now I appreciate, and I'll talk in more detail about MB2 later, it's not an easy palatal canal to find, let's be honest. And all these people who tell you, oh, it's there 90% of the time and I instrument it 95% of the time, and all these ridiculous statistics, they're not true. And they're not borne out by evidence either. That's not me or my opinion. When you look into it, if you compare an enormously sized apple with a mandarin orange, and you said, well, the apples are clearly bigger than oranges, it's not comparable, is it? And so I'll talk in more detail about the evidence to do with MB2 so that people can start feeling less bad about not finding it, and more importantly, not instrumenting it to its full working length. We do know it is there on an in vitro basis up to 90% of the time, okay? But from the Cullald and Peters paper back in 1990, they found it in 90% of cases, but they also found what they called dead end MB2s in about 25% of cases. So they said, well, okay, you could find it. And how many of you have found an MB2 where you're looking and you get in, you say, oh, that's it. And then suddenly, bang, that's it. And you say to yourself, oh my God, I've ledged it and I've done this and I've done that. It may be anatomically that is one of these canals that kind of just goes nowhere because it follows a really tortuous course. And we don't know that definitively. And of course, the acid test is its effect on outcome. But we also don't know definitively that it is a canal that we could instrument. Its effect on outcome, and I'll talk about the Walcott paper in more detail in a little while, its effect on outcome can be profound. And our identification of its effect on outcome is very important. So I think that is really, really important to be able to say, look, hang on a second, if this is a retreatment case and I didn't find it first time round, it becomes more important that you find it second time round. That makes sense. It's not me saying, well, Cullald and Peters said it was there 90% of the time. Forget that. It's you saying in a common sense way, okay, I think this could be the cause for failure here. In the same way as last week when I talked about Paul Abbott saying that if you didn't take the restoration out, you might not address the cause of failure. It's similar here. If you look at this image of this upper 6, you can see that the asymmetrical the root filling is asymmetrically distributed in the mesiobuccal root, not finding an MB2 there might obviously have a pretty profound effect on the outcome. And I've got a video here. Ignore the access cavity. It's strategically extended in inverted commas to make it easier to see. And I'm going to turn the sound off, and I will talk you through this rather than listening to my my voice as well, talking twice, which would, okay, let me see. So what you've got here is you have got an upper 6, and this is a few minutes long, so I'm going to try and speed through it if I can. So you can see there's a DG16 probe, and please let me know if you can all see this and if the video is actually working. And if not, I can send you to a link to it afterwards because it has a voiceover on it already. But if you look at this, you've got a DG16 probe, which is an absolutely critical part of armamentarium for, good, you can see this, thank you for letting me know. So you've got a DG16 probe, pointy end, and you can see it, it's poking along the floor of the pulp chamber. You're looking for your MB2, okay? So all we're doing is we're gonna keep looking for this, okay? And you can see the MB1 is the kind of dark circle. Let me just see if I can get my laser pointer working. I can. You can see your MB1 is here, okay? And your MB2 is just on the floor here, okay? And it will confuse you because you're looking at it here and you're thinking, well, hang on. But you can see the line between MB1 and MB2. At least I think that's it, unless it's over here. So a little bit of irrigant in there. And then you're going to start to access in. And when you start to access in here, and I will speed this up slightly, you're going to start with your size 10 hand file, okay? Size 10 hand file, looking in there, you've got your irrigant in here, and my fingers are in the way now here, but you can see the watch winding motion. Size 10 file in, pick, and look what I've done. I bent it and quickly get it out of shot and throw it away so nobody can see it. But I want you to look at that part because that's what happens to you clinically. We're a bit more too aggressive, we're twisting, and then you bend the top of the file. That's okay, get rid of that file, you go back in, I've just straightened it out with my finger off shot, and again, I'm finding my way in, I let it in, and then I'm watch, wind, pick, you can see the motion, but I'm also doing a little bit of filing. And then I take my hands away just so we can see that it's in the correct spot. That's roughly to about 19 millimeters, okay? And then when I speed this up, and I'll take it back a little bit, I'm now using an X1 Pro Taper Next, and it's just out of shot. You can just see it. But again, the motion is really gentle. Allow it in, brush on the outstroke. Allow it in, brush on the outstroke, brush on the outstroke. And really that's it now. That's 3 or 4 passes and no more. I don't want to go back in and in and in and in because I'll either break an instrument or I'll block a canal, one or the other. Back in, tons of irrigant, and you can see again, now the location of MB2 to MB1 becomes more obvious. And again, from the papers, they talk about this 1.81 millimeters from MB1 to MB2 in a palatal location. It doesn't help me, does it? Because I can't measure 1.81 millimeters. It's impossible. Back in with my size 10 file, it's going to go down to working length now. I'll establish my working length. Loads of irrigant in there. I've done a bit more instrumentation, and then it will become more obvious. And again, don't spray air into the cavity clinically, obviously, but you can see now, and I think I'll tilt the tooth in a second just to show you. And again, yeah, you can quite obviously see the floor. You can quite obviously see where the MB2 is, and your preparation then is done. Plenty of irrigant in again, a little bit more in terms of instrumentation. And one thing I would say is if you look at the head of the handpiece, it's kind of shaking slightly. And don't be afraid of that when you're doing that coronal access, because if you have a glide path, you're not going to break an instrument. And even if you do, in that straight coronal part of the canal, if you've created a glide path, you'll get it back out again. So you want the instrument to be engaging and kind of binding slightly, and you'll see the head of it shaking ever so slightly as well. A little bit more air, and I'll just tilt it again now in a second, just for you to see where it is. And you can see quite obviously an MB2 nicely opened up. You can see its relation to the MB1 a couple of millimeters away. And so it's the mystique associated with it. We need to get rid of that. Now, the other thing you need to consider is, and this was the question that came in for me, was how long do you look for it? Because these are the things that matter in practice. I don't put a set amount of minutes or anything on it. But what I would say is, and someone asked about the air from the 3-in-1. I definitely don't do that clinically. That was just for the purposes of the video. just so you could see a little bit better, but I wouldn't do that in a tooth, although I don't believe it would cause an air emphysema. I just am sufficiently freaked out not to do it. Because I think the chances of that happening are probably low, but it's still a chance that it could. So for me, how long would I look for it? Depends on the presentation from the patient. So if, for example, the patient did come in like that image I showed you of the upper six, and they had a failed root canal treatment, periapical lesion on the mesiobuccal root, and what looked like a single canal filled, I would think, hang on, could be an MB2. I look at the symmetry in lower teeth for missed canals. So if I've got 3 canals in a lower molar and I'm saying this looks asymmetrical, and sometimes that voice in your shoulder is saying to you, just fill it, you know, you've done so much work, it's so clean, this tooth, you know, this will have no effect on outcome. If it looks asymmetrical, there's probably a canal there, so you need to look for it. I look at the patient's response to treatment, and I think this was, the person who asked me this question highlighted this quite nicely, where they had said they just dress with calcium hydroxide and they'll reassess, and that is a totally sensible approach. Because if I have an upper six and I'm looking for 45 minutes for an MB2, and the patient has a buccal sinus and I can't find it and I dress with calcium hydroxide and they come back and the sinus is gone, chances are you're on the road to healing. I'm not saying it's going to continue that way, but it's a very sensible approach to take. And also I look at the retrieval. So I look at my ability, for example, to do an apical surgery. I look at my ability to go back into that tooth non-surgically and be much more aggressive later and say, well, you know, can I get back in there? Someone has asked, if I searched for sufficient time and didn't find it, filled the rest of the canals and the patient was still symptomatic, would I take a cone beam CT? And yeah, I'm going to cover that in a few slides time. The short answer to that question is yes, I probably would. It wouldn't just be a confirmatory cone beam CT to confirm that I'd missed the canal. It would probably be preparation for surgery as well. And actually some of the literature is a little bit conflicting in terms of its benefit rather, in terms of it finding additional anatomy. But the short answer to that question is yeah, I probably would. Now, one of the most important things is, does this have an effect? Do these missed canals have an effect? Because we all don't find canals regularly by the evidence in this paper. And remember, root canals, when you looked at Ove Peters' images from the slide showing the MB2 in the upper six, he had CT, micro CT images showing the complexity of the root canal system. Root canals are not white lines. So even if you do find an MB2, there's a chance, high chance, there's lots of anastomoses in between that are uninstrumented, uncleaned, and will be unfilled. But missed canals can have a profound effect on outcome. If you look at this paper, they found there was about 12% incidence of missed canals, okay? And that when they looked at individual teeth, mandibular incisor is very common, maxillary first molars up to 60%, which is really, really high. Distal canals in lower molars were also quite high. And these are all the ones I know from my own practice, and you guys know from your own practice, these are the more complex teeth. Of course, these are the teeth in which we're not going to be able to find these canals. Now, the question is, how do we identify this? And if you look at the incidence of this happening, it can be relatively high. But look at the radiographic appearance of the tooth. If you take, for example, a cone fit, or if you suspect there's a missed canal, or a canal that you can't find, take a cone fit and look at where the cone rests in, for example, the distal root of a lower molar, and say, hang on a sec, is it more towards the mesial or is it more towards the distal? Is there an asymmetry? Because it's giving you that confirmatory kick in the backside, as it were, to say, get back in there and look for this canal a little bit better. Not only that, but look at the canal, the pulp chamber floor, and say, okay, is there a little line? Is that lower, that distal canal, that lower molar, slightly off angle in comparison to the two mesials? Is it making a triangle, or is it making a kind of a funny wonky triangle? So look at those little hints that are left for you. And then ask yourself, is it going to have an effect on the outcome? Now, as I said earlier, retreatment cases, it's really important. But remember, this is a very famous paper by a guy called Walcott, well, famous within the world of endo, where they talked about the investigation of second mesiobuccal canals in endodontically treated and retreated maxillary molars. And if you don't read the paper, the take-home message is endodontists find loads of missed MB2s, and actually they have a big effect on outcome. And actually the tone of the paper, when it's written by Walcott, is not that at all. the tone of the paper is such that they say that they only found MB2s in 60% of maxillary first molars and 35% of maxillary second molars. And they said that although Cullald and Peters found it 90% of the time, they found the dead end MB2s in 25% of cases, and that actually other studies only found MB2s about 75, let's say, it was around 71 to 77, but say 75% of the time. So it's not there 90% of the time. So people that are telling you that are not looking at the literature in its entirety. They're looking at Cullald and Peters, which was one in vitro study, and they're saying it's there 90% of the time. Now, although the Barua paper, which is the previous paper talking about the 12% incidence and it being common in maxillary first molars, mandibular incisors, etc., although they found that it does have a pronounced effect on outcome and is a predictor of failure, you also need to consider whether or not it's a retreatment case that you're doing. So common sense would tell you, if you look at these images I've put up, you've got to be looking for an MB2 here. You have to be looking for an MB2. But equally, you have to consider the anatomical relationship. So and these are Vertucci classifications, and I can never remember these, but I can remember what a type 2 is because it's the most useful. And a type 2, as you look at it, is two separate canals joining to exit through one foramen. So if you look at what a type 2 is here, and if you miss an MB2 there versus in, for example, a type 4, where you've got two separate individual canals, of course, intuitively, the type 4 is going to have more of a pronounced effect on outcome because you have communication with the periapical tissues. And endodontics and apical periodontitis, it's a bacterial disease, and our treatment is management of that disease or prevention of that disease. So if you have a foramen in communication with the periapical tissues, you have a host bacteria immune response, and you have that war that goes on that creates the periapical radiolucency that we see and that creates the disease as we know it. So you have to have an understanding in terms of what the anatomy is and communicate that to your patient. Okay, you're not going to know if it's a Vertucci 2, but equally don't say to your patient, oh, look, we've had a look, I'm sure it'll be fine. It might not be fine. That might be completely untrue. And in terms of a consent process for a patient, I'm not going to say to a patient, oh, well, if I don't find an MB2, I might have to do surgery, the treatment might fail. It's depending on if it's a Vertucci 2, but equally be honest with them and say, I've looked really hard for this. And I'm worried that if we are more aggressive, that we will do more damage essentially than good, and that we will structurally weaken your tooth, and give them the retrievability options. We can refer you onwards. I can go back in myself and I can look again, or maybe we can consider doing apical surgery. So communicate that based on the knowledge that you have, not just based on, well, it might work or it might not work. Be a little bit more evidence-based, but in a kind of express the message in a simple way. Someone asked about CBCT, and I think it does have a role. As I said, it's not just to identify the missed anatomy, because although I said a lot of the intraoperative images we would take are confirmatory, afterwards taking a CBCT, you want more than them just saying, yeah, there is an MB2, because you're going, okay, great. Can you help me find it, please? And I think that's what you need. So you can take a bit more measurements, you can get your orientation a little bit better. You do need to have an appreciation of the dose. Not saying to a patient, oh, it's just a flight to Australia and back, because number one, the new practice after this is over, people won't be flying anywhere anyway, and they won't want to hear about it. And I say that tongue in cheek, but more importantly, have an idea of the dose. If you've got a limited volume machine, equate it to a number of small images, equate it to an OPG, explain that to them. And communicate it to them, not in a patronizing way, communicate it in an honest way where you're saying, listen, the diagnostic yield and how this may be useful is very, very important for this case. And it means that we think we might be able to get a better outcome. And that's why I'm recommending it. I'm not recommending it because I want to find out whether I found a canal or not. I'm recommending it because we're on to the next step now. And there are some issues as well. From Parker's paper here, they found actually that the use of an operating microscope, and I would say I would use that interchangeably with magnification, because they're using an operative microscope because it's not in an academic setting where they will be training endodontic postgrads and they will have microscopes. Loupes can be very effective as well. So you got to take out of the paper what you're doing yourself in practice. But they found 70% of the canals on initial access, and actually of the remaining MB2 canals where they took scans. Now it was only 15 teeth, which is a tiny number, but they only found MB2s in 5 of those. So it was actually quite a small number. The cone beam CT didn't give an enormous amount of information in terms of finding it. And I would reiterate as well, it's not just about finding it. You got to get in there and you got to make sure it's not a dead end canal like Cullald and Peter said. And Stropko said that as well, John Stropko, who's quite a famous endodontist. But you've got to get in, you've got to instrument it, you've got to get down as far as you can, and you've got to understand its Vertucci classification as well. And one other thing I would say about access is things are not always as they seem. So if a tooth looks like that and you access into it, remember, you're not always going to see a necrotic pulp, a nice dark space with nothing in there and get the characteristic smell. That is that tooth. So I remember accessing that thinking, bloody hell, I've actually perforated here. Actually, a perforation wouldn't look like that anyway, because if you perforated a virgin tooth the first time, you might get a little bit of seepage into the pulp chamber, but it's not going to look like that. But it freaked me out, and I looked at it and thought, oh my God, how have I gone so wrong with my access? But it just goes to show, never judge a book by its cover. You know, when a patient's saying to you, I can feel it, and you're saying, no, you can't. It's necrotic. It doesn't respond to pulp testing. Sometimes that's what a necrotic tooth looks like. That gave negative responses to cold and the EPT. In terms of our desired result, I don't have an answer to this. I put these images up, the one in the middle in particular, because it's one of the strangest looking root fillings I've ever seen that I have done. But you can see the access cavities here. I've tried to keep them as minimal as possible. The two on the going from left to right are ceramics. So obviously I'm trying to maintain the restoration on top. The one on the right hand side is an MTA plug in a canine, and you can see how mesily placed the access is. The tooth was originally accessed by someone else, but I liked the position of it, and I adapted to use that because I said, actually, that gives me really good straight line access into that tooth. It had a slight rotation, and so that access, and I'm holding my hands up here, and maybe it was one of you guys who did it, but I didn't do that access cavity, but it's in the right spot. But that root filling looks very, very strange. I like the access cavity because it's small, and you can see the layers of restorative material. So in terms of an aesthetic, kind of endo geek kind of way, it looks nice. But the root filling, I remember looking at it going, what is that? And that was it, showing really nice signs of healing a few months later. But it's a kind of a C-shaped anatomy, incredibly unusual. And when you talk about canal location and access, the access is probably too small to locate that kind of anatomy. And it's an incidental thing that the obturation material has gone in there. And actually the root filling, which was done by the referring dentist in the tooth behind it, to me, in conventional terms, looks nicer. But it just goes to show it's about healing. It's not about what the access cavity looks like. It's not about what the root filling looks like. It's about achieving the biological goal. And the access cavity needs to be the right size to allow you to do that. We do encounter problems. This is a case that I treated a few months back, which had a long history where the patient had a 7 extracted because of pain, and it was ultimately located to the 6, and the access was done, and you can see that the access is deviated away mesially. It was referred in relatively quickly and was repaired, and the root treatment was carried out uneventfully, and thankfully the patient has maintained the tooth. Of course, having a perforation at this point is not ideal, but the point is it happens. And I think there's no point in being catastrophic about it at that point and saying, you know, oh, this is terrible. It's about trying to manage it in that situation. The person doing it didn't set out to do it. And you can see it's completely an orientation issue, because you can see the pulp chamber radiolucency behind the access cavity. So all that has happened is depth-wise, it's actually not bad. It's away from the furcation area, but it's just the orientation's not right. It's just gone off angle. And sometimes that happens. It's very, very similar to the image I put up on the cover slide when I started, where you've got the right shape, you've got the right depth, but you're just not in the right position. And that can happen sometimes. And I think what has happened here again is a restoration and roots that are at a funny angle, and then suddenly you just lose your orientation, and then that's your issue. And this is a case I did do because, and I've shown this, I show this again to show what I used to have an image of a dog with a bib sitting in between these two radiographs, but I've taken that out to show that it's an absolute dog's dinner. And this patient was hard to manage because the patient themselves was very, very adamant they wanted to maintain the tooth, and was also highly anxious about losing the tooth, which is kind of not a great combination to put together. But I've accessed it, and looking at it, I thought, okay, yeah, access, I can do this. What I didn't realize was that there was some kind of tooth colored, I don't know if it was a post or if it was some kind of material, restorative material, right down to this level. And so accessing, with an ultrasonic, which will be a lesson to me, I went completely off angle, created a perforation coronally, redid the root canal treatment, kept it dressed for a long period of time. But you can see the healing is really, really good after 6 months. And we were actually worried initially, hang on a second, was based on the soft tissue presentation, was this something that was non-endodontic in origin? But it just goes to show mistakes happen. And I put that up to show you because you're still trying to do the right thing. I was trying to do the right thing. I spoke to the patient, I explained what happened, I talked them through it, and I said, I've repaired it really quickly. I've used the biocompatible material, let me correct myself, and I did correct myself, get into the right spot, couldn't achieve patency, but the end result is satisfactory. And the end result is a biological result, and it's not just about getting this perfect access done in a virgin tooth. You've got to appreciate that sometimes we're going to encounter problems. All of us will, and it's how we deal with them that's important. So in conclusion, I would say prepare well. So stand on the tee and swing the golf club several times. Look at the radiograph. I find myself when I'm about to access, looking at a radiograph, looking back at the tooth, looking at a radiograph, looking back. Do that a few times. Follow your instinct so that when I showed you the image from Paul McCabe's paper of the canal being calcified and it just being there and you knowing that it's there, follow your instinct. And equally, if you think I'm going a bit too deep here, stop, take an intraop radiograph and follow the map that is there as well. And the last thing I will say is there is an element of speed about it, and there will be an element of efficiency and speed, which will become more important when we go back to practice in a few weeks' time. I'm being optimistic, but I'm saying that don't force the situation. Be prepared to stop, instrument what you have found already, dress with calcium hydroxide, take another look the next time, and accept that, as I said earlier, over the course of a season or over the course of a year, these things will even themselves out. But if you adopt the correct principles, and if you adopt the same or similar techniques for each case, you will get better and quicker and more efficient and more predictable in terms of your access. So I want to say thank you very much for joining again today. I'm enjoying these. I look forward to them on a Thursday. Next week, I'm going to talk about irrigation and instrumentation. I'm going to try and keep it as relevant as I can. I try to think about these in a new kind of way, and I'm using kind of asking myself, what questions do you want answered, as opposed to necessarily just kind of going through the kind of general stuff. If there's anything else you want me to cover in terms of these seminars, I'm going to get you to email Magda, and the postman's just come into the door. It's not often you can say that when you're doing a lecture, but I'll get Magda to email, or you guys to email Magda. So just let us know what you would like from the practice in general. So do you want some case discussions? Would you like to talk about dentistry in the current climate, for example? These are just suggestions, but just send in some suggestions. I'll let Magda know that you're sending them in. So it doesn't need to be a big kind of worded email telling her what you're doing, because I know you don't want to waste your time doing that. Just lists of topics, of things you'd like covered, and the same for next Thursday as well. It's irrigation and instrumentation, but what do you want to talk about? You know, do you want me to just put cases up? Will we talk about problems? You guys just let me know. I'm going to say have a great week, and I will be in touch again next Thursday, and hopefully, you know, we can keep this going beyond the end of this as well. So I'm going to say take care to everybody, and I will see you all next Thursday. Bye bye.